Hi, everybody. It is 3 o'clock, and we'd like to welcome you to today's Rutgers Division and New Jersey Department of Health, Division of Behavioral Health Services presentation on suicide. Suicide prevention is everybody's business. Today's presenters will be Maria Kirchner and Allison Kusznikow, and she will correct me if I said that wrong. Please, wonderful, thank you. From Department of Human Services. Do I have that right, Allison? Okay, thank you very much. And so today we're going to be talking about suicide prevention, many of the initiatives in the state of New Jersey currently that will be relevant to a lot of the care that you all provide. So we have a few housekeeping slides that I need to cover before we get started. We want to welcome you again. This is an interactive training, and we encourage you to ask questions and participate throughout this session. A recording of this webinar will be available after the presentation on the Rutgers SHPRI website, which I will drop into the chat momentarily at the link on the screen. In addition to the recording of the webinar, once you complete the feedback survey, which will be sent to you tomorrow, you'll also be able to download any resources that are accompanying this training. And a disclaimer that we need to read is that the Psychiatric Rehabilitation Educational Program, PrEP, is an online forum for a variety of topics relevant to the state psychiatric hospital staff. And while Rutgers and DBHS are co-sponsors of this program, the PrEP webinars are peer presented, and as such, content is independently developed by the presenters each month. The views and opinions expressed in this program, although not very controversial, are those of the speakers and do not necessarily reflect the views or positions of any of the entities they represent. Please note that this session is being recorded for posterity, so you can access it later, but do know that it's being recorded, so anything you can say, do say, will be recorded forever and ever and ever. So we want to keep this a pleasant experience for all. I did also turn on closed captioning for anybody requiring that, or for those who, find that it accents their learning experience. So it is with great pleasure that I present today's presenters. We have Dr. Maria Kirchner, who is the Chief Clinical Psychologist for the New Jersey Department of Health, Division of Behavioral Health Services, and is the co-chair of New Jersey's DHS-DMHAS Adult Suicide Prevention Committee. We also have Allie Kusznikow, who is the DMHAS Suicide Prevention Coordinator, serving as the project coordinator on the New Jersey 988 Suicide and Crisis Lifeline team. And she also co-leads the New Jersey Governor's Challenge to reduce suicide among service members, veterans, and families. So we are very lucky to have them with us today and all of their wealth of knowledge. And with that, let's go ahead and get started. I'm going to turn it over to Dr. Kirchner.
Okay, thank you, Dawn, for the nice introduction and for putting this together. So within 1 hour, and that was the big challenge, we will try to cover basic suicide statistics, New Jersey and national, address suicide-related definitions, which is very important because they have changed over the years, highlight risk and protective factors, and discuss suicide evaluation and assessment tools. We will also give you an overview of how the field of suicide prevention has developed over the years, how to identify individuals at risk for suicide, and how to best help them. Important resources that are available in New Jersey will also be shared. I think we can go to the next slide, although before we get started, I would like you to put in the chat. Dawn will send you a link, and I would like you to follow the link, click on the link, and put all the words into this template that come to mind when you hear the word suicide. At the end, we will look at a hopefully very interesting word cloud.
Right. So Maria, I just realized that since I am the only person who is broadcasting or on my side with Zoom, I cannot do that. I cannot close the screen down and put yes. Typically,
Okay.
folks, we have, so we
we
have
had
to,
good
I'm very
intention.
sorry, we have to skip the mentee word cloud. Typically we have 2 facilitators here, but unfortunately my colleague Jen Sperduto has COVID and is very ill today. So I just discovered that I will not be able to flip over and put that in the chat, but we will be doing a poll shortly. Sorry, Maria.
Okay, we had the good intention, and it's actually quite interesting to see what words come to mind. You can do it in your mind right now without writing anything. So when you hear suicide, what comes to mind? And it's interesting, usually the variety that people associate this word with. Okay, so we move on. The learning objectives, right, would be the next one. Yeah. So I mean, in a way, it's very simple, the learning objective. It's just understanding that preventing suicide is everybody's business. And that is the title of the lecture today. But a little bit more concretely, understand that suicide is very complex, and also learn a little bit about the prevalence of suicide. Define suicide-related terms, identify risk and protective factors, and we will also talk to you about the zero suicide and other New Jersey initiatives. And now, before we really get started, we will do a quick poll right now. I turn it over to you, Dawn, right?
The poll is up. So the
Okay.
poll question is, where does New Jersey rank among suicide rates nationally? In the top third, in the second third, or in the bottom third? So we'll just give a little bit of time for, it looks like we have about 42 people participating. We'll give a little bit of time to reach about 80 to 90%, and then we will publish that poll. So
it's only either you know it or you just guess it, and just click on one of the 3.
you will not get penalized for being wrong.
No, we will not take scores here and give certificates for right or wrong. Thank you, Chris. Tragedy, yes. Pain, oh my God. People are still at on the mentee that
Yeah.
didn't really do.
But they're still doing it.
Sadness, thank you.
Okay, so I'm going to go ahead and publish the results of the poll.
Okay. Okay, so the top, okay, maybe we should have explained it better. The top 1/3 means actually, yeah, the highest. The bottom means the lowest. And in the middle, it, yeah, means the middle. So interesting enough, only 15% got this one right, because New Jersey has been historically always been on the bottom with the lowest rates in the whole country. It's usually between New York and New Jersey, or a couple of other East Coast states that are competing, so to speak, with each other. So the good news is New Jersey is definitely very low in terms of death by suicide. Let's go to the next slide, and that spells it out a little bit better. Here's the good news, and the good news is in the US as well as in New Jersey. If you look at 18, 19, 20, clearly it has come down, and that's somehow against all expectations, especially with the pandemic that we all had. So that was somehow unexpected, especially in New Jersey. If you look at it in 2018, not too long ago, 790, and now we are down to 679. And you go to the nation, was more than 48,000, and it's now just a little bit under 46,000. And I think everybody will get the slides, right? Then you can click on where the data comes from, because this is just a very, very tiny little a piece of all the data that is available on suicide statistics. We can go to the next slide. Yeah. So I attempted to show the difference between deaths by suicide and attempts. And what I also didn't write, but I explained it to you. This is all New Jersey, so this is not national, but it shows you, gives you quite some good idea what is going on here. The deaths by suicide is much less than the attempts, or putting it the other way around. Attempts in New Jersey are less than 4 times as many as the deaths by suicide, which is a wonderful news as well. And if I just make this remark about nationally, it's usually 5.5% higher. So in New Jersey, even the attempts are lower. So yeah, if you look at it, I mean, I looked at the numbers, I did the math between 2018, 19, and 22, basically no difference in terms of the percent, the compared to deaths compared to attempts. It's usually 3.9 times, 3.8 times. So it's less than 4, but very close to 4. I think that's all I have to say here.
We have one question in the chat, Dr. Kirchner, and that is, why does New Jersey have lower suicide rates than any others?
Wonderful question. And I mean, if we had the time, I would ask people what they guess, but I don't think we have the time. I want to say that there is really no statistic out on it, but my hypothesis, and I'm certainly not alone in this, is for 3 reasons. The one reason is that New Jersey is very densely populated, which means treatment centers are fairly close by. In the Midwest, sometimes people would have to drive for 2 hours. Here, you might be close to a treatment center, or the link the link can get you quickly to a treatment center. That's one reason. The other reason is really very, very, very strict gun laws. That's the other reason, and the commitment laws are also different. So I think those are the reasons. I always wanted to do research on this, but has not manifested yet. If anybody thinks there's another reason, let me know. But it's actually interesting to see how it is. If you look at the whole map of the USA, it is clearly geographically separated. So the East Coast states are the lowest, the highest ones are in the middle, and in the middle third is the West Coast. So it's really not a coincidence, you know. Okay, any other question, or that was it? No other question? Okay.
That was it. Thank you.
So the violent deaths by New Jersey residents, if you look at it, the blue, yeah, that's a good, I'm just reading this chat. Yes, when I said treatment, I actually included a support groups, and that is definitely correct. Whoever said it, yes, there is a lot of support, much more around, you know, and easier to get to. So violent deaths by New Jersey residents, the absolute highest is clearly suicide with almost 65%. And then second one is homicide, which is almost, no, it's actually less than half. And then the unintentional firearms is it's very, very low, very low. It's the 0.3. Undetermined intent is almost 6. And the 1.0, that's legal interventions. And I think everybody knows what this means. It's deaths due to injuries inflicted by police and law enforcement agencies. Okay, any other questions to this slide, or can we move on? Okay, a little bit more statistics. And I want to emphasize here what the slide that you'd see here, that's actually true for males, a little different for females. I had 2 slides, but I was told to cut down, so it left, I'm sorry. Hanging is the highest one. And again, it's New Jersey, but it's very similar to the whole nation. Hanging is the highest one. Firearm among male is the second one. Poisoning among male is the third. Yes, we will get to this. I just read the question. Yes, it's definitely, yes, I will. There's a slide that will cover it. So then the jumping and the drowning, and I give you some idea, like hanging for male was 754 and firearm 517, and then it goes down, poisoning to 200. However, for women, the hanging is 237 versus 574. What a difference. And a firearm is only 158 versus 517 for male. Poisoning, it's the only category that a female are higher. It's 207, or it was 200 in 2018, was 207 and 200. I'm sorry, I didn't see the question. Should we address it now?
Sure, we have a couple of questions. And one was, is suicide always considered a violent death? And 2, does poisoning include overdose?
Good questions, very good questions. Yes, poisoning does include overdose, and there are quite some discussions. How much is it suicide? How much is it overdose? And I wish we had the time to go into this, because it's really interesting. If you compare the maps of New Jersey between overdose deaths and deaths by suicide, very, very similar. It's amazing, but I cannot really get into this because we don't have the time. The other question I will address with another slide very, very soon. So the location, home, mostly in their own home, sometimes in somebody else's home. I actually have a patient whose sister died by suicide, and she chose her sister's home while she was not at home. So it happens too. Then nature is the second one, motor vehicle is the third one, hotel, motel is prison, is the fourth one, prison or jail is the fifth one, and then there is a very small category which covers hospitals and medical centers, which is also good. And for those people who work in the hospitals, you know that it is very, very rare. Thank you, God. That's really good that actually a death by suicide happens in the psychiatric hospitals or even in any other hospitals in New Jersey. It's very, very, very small. I think we can go on to the next page. Yeah, so that's interesting because this all comes from CDC, that 45% of people who died by suicide had contact with primary care providers 1 month before their death. And then among older adults, this statistics jumps up to 78%. Any idea why this is the case? You know, we cannot really listen to too many people. Often in older adults, emotional pain manifests itself in physical pain. So they go to their primary care physician because they think maybe something is wrong. And that is definitely one explanation. And I must say, and Ellie clearly knows it too, 2 years ago, we dedicated a whole conference, suicide prevention conference, to primary care, because it seems to be really important to check right there. And some of you who maybe have been at a primary care doctor recently, you probably have gotten a suicide screener or a depression screener or both. That's more and more common practice now. And then 19% of people who died by suicide had contact with mental health services. That's different from primary care, obviously, in the months before death. So definitely fewer people mental health than primary care. About 1/3 were receiving mental health care. And 10% of people who died by suicide were seen in an emergency department in 2 months before death. I personally thought this number is higher, but that's the official number. I think we can go on. Okay. I promised you to go to this one. It will come, it must come. So this is really interesting, and I want you to really take this seriously, that some of the words we just used to use without thinking much, they are really frowned upon, to say the least. They're just not acceptable anymore. So we are not saying committing suicide anymore. Why? Why is this not okay? It's all stigmatizing language. And committing suicide, it has two reasons, actually. Committing can be a criminal act. And as you know, suicide was considered criminal in some religions. Maybe it still is in some. And then it's also, if we are committed to a task, so we put all our energy into a task, and we usually combine it or associate it with something positive. I'm really committed to getting better. I'm really committed to therapy or whatever. So, and then what we do is say instead is suicidal self-directed violence, or we also talk about non-suicidal self-directed violence. And for those of you who work in our psychiatric hospitals, you very well know the difference. There are many people who don't want to die, but they do a lot of self-directed violence by cutting or mutilating or banging their head. And then there are other patients who really want to end their lives, and that's when we call it suicidal self-directed violence. And that is to distinguish from other directed violence. So let's go back to the non-acceptable: committed suicide, completed suicide. I mean, if it's suicide, it's suicide. We don't need the completed suicide. Successful suicide, absolutely no. Usually when we are successful, we have achieved something, and that is not good to associate it with death. Failed attempt, suicidal gestures, we are not seeing anymore. Manipulative act, we are not seeing anymore. And even suicidal threat, we are not seeing anymore. And we often had big discussions, long discussions, why not? And we cannot get into this once again. I should probably even be a little aware of the time. Now we are still doing good. So we always say death by suicide. We talk about suicide attempts. We just say suicide, or then we talk about the self-directed violence, whether it's suicidal or non-suicidal. Any questions or comments? Okay, so thank you for moving forward. This is really very, very important, and it sounds very simplistic, but it's actually not. One big factor or characteristic is suicide risk is not static, and it is complex. So it's not static. That means it can change. Even the same person who had an attempt maybe a year ago and an attempt maybe a week ago it is not static. It might be very different. The reasons might be very different. And we will learn a little bit more about it, how complex suicidality is, you know. There's no single cause. It's usually a result of several converging factors. And if you go on the CDC website, Viscus, they have a statistics on what is the most common cause. It's usually relationship problems that's ranks high up, and then problems with the legal system that's a little bit lower down, you know. Because it is not due to a single cause, that's also, I'm sorry, the third bullet point even has it here. So relationship problems is very high, substance use clearly very high, and some of you probably know even more about it than I do. I saw Chris Dorian being among us, so you know it. Physical health problems, especially in the elderly population, often job or financial problems, and the criminal legal problems, as I told you, is more towards the end. So it's so important to understand the risk of suicide on a continuum. Okay, yeah, I think I gave you, I just read it, I'm sorry. I think I gave you some examples of non-suicidal. That's cutting without the intention of dying. It's headbanging without the intention of really getting harming yourself, or harming, the person harming her or himself to the degree that the person would die. Even pills, taking pills. I mean, we had suicide attempts where a person wrote a goodbye letter and just took 3 Tylenol or 5 Tylenol. Yeah, maybe the person wasn't really, didn't really want to die. I'm sorry, there was just something I saw very briefly. Despair, yes, exactly. You're absolutely right. That's more out of despair, out of the emotional pain, but not necessarily to really end their life. Yeah. Is this good enough in terms of, did I give you some idea? Yes, no? Okay. Good. So where are we now? Oh, I still have the chat open, sorry. Yeah. So as you can see with those arrows, which is really nicely done, I cannot take credit for this. It was really Dawn and Chen who did it so nicely. Because everybody has some risk and some protective factors. And what we try to achieve in preventing suicide is minimizing the risk factors, the red arrow, and maximizing the protective factors. Yeah, strengthen, support, and protect. So examples of risk factors is psychiatric history, often substance use, we already touched on it. Then also, if there was a history of attempts, it doesn't even have to be the person, him or herself. It can be if an uncle, a sister, a mother, a father did this too, or even among friends, you know. Illness, pain, losses, money issues, social isolation, that's a big one actually, hopelessness and mood changes. And then the protective factors, it's always to encourage the connectedness or life skills. Many groups in the hospital or treatment modalities are geared towards enhancing life skills. Overall, also enhancing self-esteem, purpose of the purpose or the meaning in life. That's a really big one too, a purpose or meaning of life. And then also often the cultural and religious beliefs. Those are protective factors. And I don't know, Chris, if you feel comfortable, maybe you want to just share with the audience what we discussed before, because I think that's a really good point you made before about the empathy. You want to say something? Can I put you on the spot? No?
Oh, there we go. You hear me?
Yeah, I can.
Okay, so I guess you're referring to earlier when I mentioned that for many a protective factor may be almost like their sense of empathy or like worrying about how it would impact others. And I thought that that was something, I mean, maybe misattributing to something of like the more younger generation, but because of the understanding of mental health, mental illness, and more willingness to connect with those services.
Yes.
You know, but it definitely anecdotally, what I've pulled from talking to people is that they would have attempted suicide or attempted to kill themselves had it not been for how they thought it may impact others. And that was the sole thing keeping them from doing that.
Yes, thank you so much. I thought
You're
it
welcome.
was really a good point, and I can corroborate it from my private practice. I have quite a few people, they clearly say, if it weren't for my children or my mother or my father or my sister or whatever, I would like to end my life because it is so emotionally painful, but I'm not going to do it. Believe me, I'm not going to do it. And I actually do believe them, you know. So I might add this the next time on the slide. Okay, I think we can go to the next, yeah. So the warning signs of suicide, I think it's pretty clear. If you hear somebody talking a lot about suicide or death, or the wish to die, it does not mean yet that the person is really actively suicidal, not at all. But I would be better off dead, or I have no reason to live. Everyone would be happier if I weren't here. So I often share this story. When I worked in the psych hospital, I had a patient who said every single day, I pray to God that he would take me. I really want to die. He was never actively suicidal, and he did die actually, but not by suicide. So he did talk a lot about suicide, but not necessarily actively. There is such a thing as passive suicidality, which we cannot cover today either. Maybe next time we can go into all those special areas, you know. Another, and as you can see from the colors, so buying or storing things that can be used for suicide becomes a little bit more serious. The purchase or collection of medications or guns or any kind of weapons, you know, if somebody hoards them, you probably should be suspicious and try to avoid anything bad from happening. And searching the internet for methods of suicide, that's another big clue. Or preparing for your own death, making sure that children, pets, elderly parents will be cared for, updating wills, financial arrangements, saying goodbye to loved ones, or giving away possessions, you know, oh, just take this, you know. And then, and those signs are even more dangerous and serious if the person has some kind of history, previous attempts. It doesn't really matter how long in the past it was. Of course, if it has been 30 years ago and there was nothing in between, less likely that the history counts for so much. But if somebody just attempted suicide within the last 6 months or 4 months, you know, I had a patient within a weekend, over the weekend, had 4 attempts. So, has a family member or close friend who died by suicide. As I said already, it's not just the attempts for the person, him or herself, it's only any kind of family member or close friends. Plans to use and has access to an effective method. And that's also very important that we ask for guns, you know, like I'm a psychologist in private practice and work in the psych hospitals. So if I learn that somebody, or if I suspect that somebody might be really actively suicidal, by law, I'm required to report this to the police, so the police can then go and search their home for possible weapons, especially guns. I have never had this experience, but I just want you to know this. That's a new law in New Jersey. It's not in every state, but it is in New Jersey. Okay, I think we can move on. Yeah, so screening and assessment of risk for suicide, no matter what kind of screening or assessment tool it is, hopefully it is evidence-based. And for those people who work in the hospital, you know what is mandated. I think you know. And it's also the gold standard. It's considered the gold standard of all screening and assessment tools. And that's the Columbia Suicide Severity Rating Scale, is CSSRS, Columbia Suicide Severity Rating Scales. They have screeners and they have assessments. And they have, last time I counted, was more than 40 different versions. In the hospital, we only use or mandate to use 1, 2, 3, 4 versions, I think, 4 only. But keep in mind, screening and assessment tools, they can only aid in the process of uncovering suicide risks. They can never, ever predict. They can only estimate what's the likelihood, you know. What is really important is the clinical judgment and looking at contributing factors like the suicidal ideation, the plans, the intent, behavior, availability of lethal means, as we just talked about, the presence of the risk factors and warning signs, protective factors, and the patient's clinical presentation. And those are areas, categories. Those are categories that assessment tools, the CSSRS, covers. So in the hospitals, it's usually I think not usually, it's always the psychologist who do can also be the psychiatrist, of course, or the APN. They can do the assessments. Screening is also nursing can do the screening. And there is a very interesting website for the Columbia. It's under Lighthouse, and they offer trainings, and it's really good. Everybody who has to do screening or assessment in the hospitals, they are mandated to take their trainings. Okay, I think we can go to the next slide. Any questions here? Anything I should know? No, I didn't look, but there is no other question, right?
Oh, no other questions.
Okay. So the steps to help someone at risk, there are always immediate actions, which is very clear. Keep them safe. That's the most important. Be there for them. Don't leave them alone. And ask the question directly. Ask the question directly. Not dancing around, but do you want to die? Do you want to kill yourself? That would be a direct question. And the long-term actions, of course, are always helping them to connect, as we know that social isolation or not being connected is a huge contributor. Emphasize positive traits. If somebody really is very hopeless, they cannot even see their strengths or all their positive traits, remind them. Most people, especially when they are older, I mean not like 5 or 10 or 15 anymore, they have accomplished something, you know, and we can emphasize this. and then refer to healthcare, because after all, that might be really indicated. And I would say anybody who has a high suicide level of suicidality, probably healthcare, referring them to healthcare and that treatment is probably very important. And we talk a little bit in the next slide about treatment. Okay, so in the hospitals and for acute, for imminent actions, pharmacotherapy, pharmacological interventions are very important. And yet there is no pill for suicide. It really is not, or against suicide, to stop, prevent suicide. There is no pill. But of course, if there's an underlying deep depression or underlying high levels of anxiety, psychotropic medication can help. So in terms of the motivational interviewing, that is geared towards treatment. If somebody said, oh, I don't know, should I really go into treatment? The motivational interviewing can really help to motivate somebody. Then there is a very specific, actually the next three, they're all specific treatment modalities for suicide prevention. The one is cognitive therapy for suicide prevention, or CBTSP. The other one is dialectical behavior therapy, DBT, and I think in all hospitals this is offered now. Wonderful. Was not around a couple of years ago, but now it is. And now safety planning interventions, that's actually also mandated in the hospitals for patients with any kind of moderate or high risk of suicide. So, and it is really an evidence-based treatment modality. Okay. Almost done. The environmental risk assessment. Of course, you all know it. Whoever works in the hospital, you know that a lot is done to minimize the risk. Removal of anchor points, the door hinges, the hooks are different. Faucets are very different. They're all rounded. Soap dispensers. And in general, if you're not in the hospital, or even if you're in the hospital, just scan the environment, you know. I mean, if there is if there hangs like from blinds, if you see some cord hanging, just be aware of it, you know. Some things can really pose a risk, and you might, under normal circumstances, not register it. But if you have a suicidal patient or person around you, be aware of this. Okay. QPR, everybody who works in the hospital has to get a beginning training on QPR. It's really called a gatekeeper assessment. It stands for question a person about suicide directly, persuade somebody to get help, and refer somebody to the appropriate resource. It's more geared towards the community, and yet also for the hospitals, we use this as well. Okay, I think that's now much more a recap already. Since there is not one single reason, there is also no single prevention activity that will avoid worst case scenario. And all prevention efforts needs to be comprehensive, multifaceted, and coordinated. So it starts often with another individual, and then it goes to family, it goes to community, and it goes to state efforts. So everybody goes back to everybody plays a role in suicide prevention. And I think that's all I have to say to you today, right? Ellie, you're ready to take over?
I'm ready.
Not yet. I'm sorry. I'm sorry. One more. That's fine. Yeah, I told you already that over the last, actually by now it's almost 20 years, a lot of research was done. And through the research, we learned really new things, you know, and that caused a shift in perspective. Now, accepting suicide is as inevitable is no longer okay. Every suicide in a system is preventable. That's what we believe in a system is preventable if everybody does their job, you know. Assigning blame, now we have a nuanced understanding. Risk assessment and containment, that was all we did. We assessed the risk and then we removed everything from the person, and now we have a collaborative safety, treatment, and recovery. Standalone training and tools. Now we have this culture change that everybody plays a role in it. Specialty referral to niche, to just to certain staff. Only the psychiatrist is responsible for preventing suicide. Not at all. It's part of everyone's job. Individual clinicians' judgment and actions. No. Standardized screening, assessment, risk stratification, and interventions, and evidence-based. And now I turn it over to Ali.
Thank you, Maria. Yeah, you can go to the next slide. For the past few years that I've worked with Maria, I've probably listened to a part or some sort of combination of her presentations dozens of times, and it never gets old because they're so rich with information. And as a suicide prevention coordinator, I'm honored to be presenting alongside of her today. And, you know, I'm just going to recap really quickly here on these key messages, but it's always a pleasure to listen to Maria's presentations and also present with her, because there's always so much to learn and to know about this very important topic. So I'm just going to recap really quickly before we move on. Just with everything that she just went over. I know it's a lot of information, very in-depth and rich information, important information, but there was really 5 different and very important key messages that she went over. Healing, hope, and help is possible. Everyone can do something to prevent suicide. Asking and addressing the issue of suicide is vital. Safety plans, wellness, recovery, and action plans do work, and everyone has a role in helping to prevent suicide. Next slide, please. So with that, I'm going to move along into something that New Jersey has implemented, or that they did implement a few years ago to really start the groundwork for preventing suicide in our systems. So, you know, Maria just really talked about all of the important ways of assessing suicide risk, how to manage, and whatnot, all of the really important clinical pieces and components of it. So now with my position, I'm just going to go through and talk about what New Jersey has been doing, especially through the Department of Human Services. That's where the suicide prevention unit is. So the New Jersey Department of Human Services, Division of Mental Health and Addiction Services, received funding in 2020 to adopt the Zero Suicide Framework. Zero suicide models, what it takes is it makes a system-wide organizational commitment to safer suicide care. Zero suicide is based on the realization that people experiencing suicidal thoughts and urges often fall through the cracks in a sometimes fragmented and distracted healthcare system. Studies have actually shown that the vast majority of people who have died by suicide saw a healthcare provider in the year prior to their deaths. So this really gives an opportunity for healthcare systems to make a real difference by transforming how patients are screened and the care that they receive. The foundational belief of zero suicide is that suicide deaths for individuals under the care of health and behavioral health systems are preventable. For systems dedicated to improving patient safety, zero suicide presents an aspirational challenge and practical framework for system-wide transformation towards safer suicide care. Overall, it's a way to improve suicide care within health and behavioral health systems in a nutshell. Next slide, please. The framework itself was built around these 7 core components that you see in front of you in this puzzle piece circle. It was designed to implement a safer suicide care, and you're probably going to hear me say this a ton of times, but it's really their the crux of everything that Zero Suicide and the Education Development Center does. So during training for systems that get involved in this framework, this is the detailed guide to implementation and strategy. Everything is really based around these 7. So really quickly, I'll just give like a quick explanation for each of the 7. It starts with LEAD. That is a system-wide culture change committed to reducing suicide. Train a competent, confident, and caring workforce. Identify individuals with suicide risk via comprehensive screening and assessment. Engage all individuals at risk of suicide using a suicide care management plan. Treat suicidal thoughts and behaviors using evidence-based treatments. Transition individuals through care with warm handoffs and supportive contacts. And lastly, improve policies and procedures through continuous quality improvement. So on their website, you can find the toolkit, research, tools, even videos to walk you through putting the framework into practice. Their website is full of information. It is it's a portal of just anything you need to know. The toolkits are actually really, really helpful. And I want to stop real quick there and see if there's any questions. I haven't looked at the chat.
No questions at this point, Allie.
Okay. All right, I'm going to keep going then. So next slide. So about New Jersey specifically, in 2020, we in New Jersey hosted the first ever Zero Suicide Academy. We hosted 3, actually. They were hosted in the fall of 2020, and 30 agencies in total spanned out over the 3 joined. They committed to being a part of these academies. The academies were designed to be half-day trainings. It allowed for multiple workshops, presenters, and all lessons. It was all virtual, which was the first time for us and for EDC. If we can all remember, 2020 was a very interesting time for virtual life, and even EDC, the Education Development Center that put this on, was new to them as well. So, the 30 agencies that were part of that are they're doing really great through the entire process, given what we were able to use back then in 2020. So to encourage a continuation of growth and learning, next we did community of practice sessions, which are designed to facilitate group learning and to assist the agencies in their first years of implementation. These community of practice sessions are designed to be 9 months right after the academy. So that ended in January of 2020. We kind of started a little bit late after the academies were hosted, again, just because of COVID and the times that we were going through, and we weren't sure exactly how we wanted to design community of practice sessions. They can be pretty flexible. But now the teams, even though the communities of practice sessions are over, they have chosen to meet on a quarterly basis just for any check-in and support needed. So I just like to mention that because it goes to show that these teams really want to be part of a bigger team that supports one another and is there for all stages of their implementation. Next slide, please. So I'm excited to announce that we are currently working with the Education Development Center, EDC, again, to host additional academies. This future program is still being worked on between us and their agency, but there is an agreement that sometime within this next year, 2 more academies will be offered for agencies to participate. So information on that will be coming. I don't have anything official to give or answer to or to put in the chat for it right now, but it is something that we are working on, and we're very excited about it. All right, and now Dawn, if you want to pull up the 988 website, I can kind of go into that.
Sure, I just have to stop sharing, and I will navigate to that.
So while Dawn is pulling that website up, something that I did not want to leave out of this presentation today is I just want to kind of briefly mention something very important that not only our state, but our country did this past summer. I'm sure you all have heard of it by now, but on July 16th of this year, the National Suicide Prevention Lifeline transitioned over to the 3-digit number 988 for suicide prevention and mental health and substance use crisis. Cool. So this number is available 24/7, 365 days a year. There's a chat you can access on the website, along with texting from a mobile phone as well. As you heard in my bio, I am on the New Jersey 988 team. I'm the project coordinator. So we have been working on this since January of 2021 to prepare for this transition. So a lot of work has gone into it. New Jersey already has a strong acute care and crisis response system in place, but we are working very hard to develop and implement additional programs that will establish the system as a comprehensive response to people experiencing any crisis. So from the start of the transition in July, there was a 60% call volume increase nationally and a 20% increase in New Jersey. So I'd just like to point that out. It's November and we expected this increase, but it just goes to show that we are working very hard to make sure that our state and our centers are able to support this. And we are, which I'm very happy to report, is that we have been seeing a very smooth transition and smooth response to this call volume increase. So you can find a very detailed presentation about 988 on our website. I know we only have a couple minutes left, and I just wanted to mention and acknowledge 988 for our state. So this presentation is on the website that Dawn just had up. It's actually a recorded presentation that Mary Jean Weston, she is the project lead for 988, also at the Department of Human Services. And it was uploaded to YouTube. So I'm actually going to drop the link into the chat when I finish up if you want to learn more about it and just get the very interesting details all about 988. It's a very, very interesting presentation. Since it's on YouTube, you can kind of skip through and see all the slides and whatnot. And
you
yep.
you might also want to mention the New Jersey Hope Line, because that is specific for suicide, and the 988 is more mental, also for suicide, but much broader mental health, you know. So,
yep. So Maria is right. The Hope Line is through Rutgers. It is a contracted call line, supported call line through our division. It is specific to New Jersey. So if someone were to call 988, you will be transferred to a lifeline center that is specific to like your area code on your phone. But if you call the Hope Line, you are guaranteed to get a specialist in New Jersey that will be able to help you get to services specifically to like the county that you're in. Just, it's a more specific resource to call. So thanks, Maria.
Allie, we do have one question that came in.
Sure.
And that was, do you think that the call volume increase is due to the ease of the number? So now it's just these, they don't have to remember a bunch of numbers, or maybe they're happy that they don't have to call 911. I don't want to, maybe happy is not the best word, maybe relieved that they don't have to call 911 versus 988, which is more mental health specific. So do you think that the call volume increase is due to the ease of the number or the need for more suicide prevention assistance? So are people feeling more suicidal?
It might be, it's most likely both. I mean, there isn't specific data right now that tells us either way, unless there was, some sort of survey that goes out when someone dials the number. But the idea is that 988 has been marketed and like broadcasted and put on so many social media campaigns. It is on the back of some high school students' student ID cards. It is just being blasted everywhere. And I think one that poses an interest to people to just try and call. I've even done it. And then when, someone answers, I say, oh, this is just a test call. I work for blah, blah, blah. So even me calling adds to the data, right? As doing a test call. So there's many reasons why the volume is higher. I just think that it poses an interest, but I also strongly believe that the way that they have been pushing the number and the idea of what people can receive on the other line when they call has given people the confidence to call and receive the help that they might need. I don't know about you, but I have heard 988 so often in the past year, whereas I did not hear the NSPL, the National Suicide Prevention Lifeline, even close as much before that. It's just talked about so much, 988.
Thank you. Thank you
Yep.
for
I
addressing
hope
that.
that answers the question.
Yeah,
but-
and just to let you both know, we have 1 minute.
Yep.
So if
I
you
was
want
just gonna say if there was any other questions, and I want to put that link in the chat before we hang up, because then it'll be gone. So I'm gonna drop that in the chat now. And please copy it, put it into your browser if you wanted to get some more information on 988. But other than that, I'm grateful that I was asked to present today alongside with Maria. So thank you.
Thank you.
And I want to thank everybody for attending today. It is 4 o'clock. So I want to just put one more pitch out there for any questions that anybody might have before we abruptly wrap up. As if you've attended any of our other webinars, we're pretty serious about ending at 4. So any other questions? And of course, obviously, I think that probably I'm going to say definitely that Dr. Kirchner or Allison would definitely welcome questions, or you can also shoot them to the SHPRI team, and we can relay those questions to both Dr. Kirchner and Allie. Thank you all for attending. Please, when you get a chance, follow that the the webinar feedback survey that we put in the chat. You'll be able to then access additional resources once you have done that. And we appreciate your attendance. We hope you have a wonderful evening. Stay warm and be well. Thank you all.
Bye.
Thank you. Bye.